Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Ground Rounds this week, where Dr. Jonathan Bailey, an anesthesiologist and associate professor at Dalhousie University, discusses regional anesthesia of the trunk. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
So we're going to be talking about regional anesthesia of the trunks, both the chest and the abdomen. During this talk, I hope to just review the innervation of the chest and abdominal wall to set the stage for what we're about to talk about. We'll talk about some distribution of common fascial pain blocks, and then try to determine the appropriate technique for each type of major incision. And mixed in throughout the talk is a bit of a debate about surgeon-placed versus ultrasound-guided fascial plane blocks. Before I fully get going, I'm just going to recognize where I'm presenting from. So Dalhousie operates on the unceded territories of the Mi'kmaq, Molastoqua, and Pistotogumaki peoples. And these nations all hold inherent rights to this land. We're here long before us, and we all hold collective obligations under the peace and friendship treaties. And I'm honestly, as much as I miss Saskatchewan, I'm really glad that I live where I live and able to work where I do. So I don't have any financial disclosures for this talk. My main conflict of interest is shameless self-promotion, which is half of the reason why I do these. So here's a list of my socials if you care to follow me there or have discussions about this afterwards. So as much as we're shifting towards minimally invasive surgery, and that's great, and I think we should as much as possible, major surgery, major open surgery is still a reality that happens fairly often. Abdominal surgery is performed at hospitals of every size worldwide. From 2017 data, about just over 50% of acute care general surgery admissions went on to some kind of surgery, and 55% of those were open surgeries. And thoracic surgery is still alive and well, thanks in part to past and continued smoking rates. And those are declining nationally, but then we've got a resurgence of smoking other things like vapes and cannabis, and radon is still a reality. And so prevalence of lung cancer varies from 54 to 90 people in 100,000 nationally. So that's true of most places across the country. So the first question you're probably going to ask is, well, why not epidurals? With that, we've basically solved this problem. You can place an epidural anywhere you like along the entire spinal cord. It works super well, blocks everything, pretty reliable, and is honestly the gold standard for pain control after open surgery. And I'm not totally against this idea. Several years ago now, we did a systematic review that compared epidurals to continuous peripheral nerve catheters, or mainly fascial plane blocks, versus multimodal alone. And while pain and postoperative nausea and vomiting were the same amongst all three groups, we did see that epidurals were superior to fascial plane blocks for both opioid use and length of stay, and those were superior to multimodal alone. However, even though traditionally the most common regional anesthetic technique for abdominal surgery is a thoracic epidural, epidurals come with some potential downsides. So first of all, there's common complications that we come across, and that is hypotension is reasonably common, which limits the amount of dosing that we can do due to the sympathectomy. If you've included opioids in the epidural mix, Pruritus is a common problem. Urinary retention is a reality. And then getting to a little bit less common things, post-dural puncture headache is not insignificant, maybe, a little less than 1%. Um, and then kind of newer studies looking at epidural hematoma suggest they're a bit more common than we once were quoting. So they happen at about 1 in 3,000 and 1 in 6,000 epidurals. And abscess is a wider, estimate, but 1 in 1,300 to 14,000 approximately. Those transition into a permanent neurologic injury at a rate about 1 in 24,000 to 1 in 54,000, according to the NAP studies in the UK. So it's rare still, and these are good quality blocks, but these complications are not nothing. So, to transition to talking about some other things, I want to cover some of the innervation of the chest and abdominal wall just to set the stage. I know you all know this kind of somewhere in the recesses of your mind. Um, so let's start by looking at the chest wall. So first of all, nerve roots come out at every level, and as they leave the spinal column, they separate into dorsal and ventral rami. The dorsal rami innervate the paraspinal muscles and the skin along the midline back. The ventral rami become the intercostal nerves. Intercostal nerves then travel in between the innermost and the internal intercostal muscles before dividing into lateral and anterior branches. The lateral branch pierces through the intercostal muscles and the serratus anterior muscle at about the mid-axillary line, and then they form anterior and posterior branches. So this lateral branch is responsible for innervating the lateral chest wall and basically covers between the mid-clavicular line from posterior to anterior. The anterior branch continues on in that same plane in the innermost and between innermost and internal intercostal muscles. In the anterior thorax, the innermost intercostal muscle thins, and then close to the sternum, it becomes the the transversus thoracis muscle. And just lateral to the sternum, the anterior branch then pierces through those muscles and comes out giving off medial and lateral branches and basically covers the midline chest. So then, simply put, when you're dealing with lateral incisions, it's the lateral branch of the intercostal nerves that you're targeting. And if you're dealing with midline incisions, you're dealing with the anterior branch of the intercostal nerves. There are several fascial plane blocks that target the intercostal nerves kind of along their path. So near the sternum is the parasternal intercostal plane block. There's the pectoserratus or interpectoral plane blocks. Those used to be called the PEC blocks. There is the serratus anterior plane blocks, both superficial and deep. And then there's the paravertebral by proxy blocks that are either the erector spinae plane block or the intertransverse process block. And of course, the classic paravertebral. The anterior abdominal wall. So the abdominal wall is analogous in that the intercostal nerves become the thoracoabdominal nerves. So they start off as intercostal nerves traveling in the same plane we just talked about. Once they breach the costal margin, typically refer to them as thoracoabdominal nerves. So the lateral border or the lateral side of the abdomen is still the lateral branches of those thoracoabdominal nerves, whereas the midline would be the anterior branches. So those continue along. Once they come past the costal margin, they enter the transversus abdominis plane, sitting in between the transversus abdominis and internal oblique muscles. And then they pierce the side of the rectus sheath, travel along the back of it, and close to the midline, they pierce through the rectus muscle, come out through the anterior portion of the rectus sheath, and then innervate the skin overlying it. So there have been several different blocks again described to target all of these nerves. Of course, as we talked about, the king of all blocks, the epidural, paravertebral, erector spinae, intertransverse process blocks all apply here as well. There's a relatively newly described block called the external oblique intercostal block that I'll talk about later, the tap block, and the rectus sheath block. And those are kind of the ones I'm going to focus on today. But first, a couple of disclaimers. So I'm going to talk primarily about nerve blocks for this talk. Of course, I'm a big proponent for multimodal analgesia in general, but unfortunately, there's not enough time to talk about that and blocks. So I opted for an overview of blocks for trunk procedures rather than going in depth on any one particular group of procedures for this talk. Secondly, I fully acknowledge that the alphabet soup of regional anesthesia can be fully overwhelming. And in fact, I wrote a whole editorial about this exact complaint that it's getting out of control. And some of this, unfortunately, is a little inescapable since there are many blocks and with slight variations on needle endpoint, they have different distributions. But I've tried to reduce this to like kind of the most practical or meaningful blocks and limiting kind of overlap of names. And lastly, I'll try to keep this practical, but honestly, some of this is a little aspirational. This represents what I think is ideal care, in my opinion, but it doesn't always mean that we do this here at Dalhousie. So, if you're talking to my colleagues and they say we don't actually do this, well, maybe not. So for starters, I'm going to focus in on video-assisted thoracic surgery and minimally invasive cardiac surgery. The European Society of Regional Anesthesia and Pain Therapy has put out a series of guidelines regarding pain management. These are procedure-specific guidelines, and that's actually what PROSPECT stands for, is procedure-specific postoperative pain management. So these guidelines that I'm here are about VATS procedures in particular. There are 3 different fascial plane blocks that are listed as recommended with grade A evidence for single shot injections for VATS. And those are the paravertebral, the erector spinae plane block, and the serratus anterior plane block. Continuous infusions are also supported, but there still need to be some non-inferiority studies between single shot and catheters to confirm that. So interestingly, in these guidelines, they also directly say that they don't recommend a thoracic epidural for VATS procedures because of non-inferiority to less invasive techniques with fewer side effects. This avoidance of epidurals is actually echoed by the the ASA practice guidelines regarding specifically cardiothoracic surgeries. And these are the brand new 2026 ASA practice guidelines for cardiothoracic mastectomy and abdominal surgeries. And the Society of Cardiovascular Anesthesiologists Quality, Safety, and Leadership Committee has said close to the same thing. So while they recognize the use of thoracic epidurals for VATS, they go on to say higher frequencies of hypotension, pruritus, dizziness, and urinary retention are seen in the thoracic epidural group compared to the paravertebral group. And so part of the reason why I'm motivated to talk about blocks in thoracic surgery specifically is that we recently surveyed thoracic surgeons across Canada about pain management practices. And we found that compliance with the PROSPECT guidelines was quite low. And in fact, there's no respondent that was in full compliance with the guidelines, and only 43% were in partial compliance. And much of this was you can see both block and analgesia compliance is fairly low. The compliance with blocks overall was 30%. And part of that is that quite a few of them were still placing thoracic epidurals specifically for VATS. And of the 3 recommended fascial plane blocks, only 21% of respondents replied that they were being routinely placed in their patients. So briefly, I'd like to talk about a few points relating to some of the recommended blocks. So we'll start with, I call the epidural king of all blocks, but this is the king of all peripheral blocks, is a paravertebral. So paravertebral blocks will cover both the ventral and dorsal rami in addition to the sympathetic chain. And And so that will allow you to block the entire chest, normally about 5 dermatomes, with an injection of 20 mils of local anesthetic. So it goes from about 2 dermatomes above and below the point of injection. So you just try to line this up with the thoracotomy incision or the midpoint of any VATS procedures. Every transducer and needle orientation has been described for this block since it's been around for so long. So the transducer could be transverse or paramedian. The needle could be in plane or out of plane. I personally prefer an in plane parasagittal approach because because the needle angle is steep, an echogenic needle is definitely preferred. And it has to be steep because in this approach, in order to avoid the transverse processes, you just have to have a steep needle angle approach to get into the paravertebral space. So I often use dextrose or saline as a test injection on the way down to see little puffs to confirm where the needle tip is. But honestly, this is actually a difficult block for any of us to place, and it does take time. And for people with thicker backs, which you may have some of those patients, it's really hard to obtain good or safe imaging. So that's why you may want to consider for this one talking to your surgeons about learning how to place paravertebrals under thoracoscopic guidance. I'll show you a video here of our, well, if it'll load, um, of our surgeons placing a paravertebral under thoracoscopic guidance. If it can run. The beauty is that from a thoracoscopic point of view, this is um, you can see this directly. You can see the sympathetic chain directly. And then place the catheter directly beside it. Watch the local spread across. All right, so yeah, this is one of our surgeons placing a thoracoscopically placed paravertebral. So you can see it starts off as kind of intercostal plane, but then it spreads up and down along the sympathetic chain. So this is actually covering right over the sympathetic chain. And then next, you'll see them advance a catheter under direct guidance. And if you look closely, you can see the tip directly, it's touching the sympathetic chain. Now, from my point of view, seeing your catheter directly contact the nerve is going to beat ultrasound every time. So it's kind of hard to argue against them for this one, and they tend to work pretty consistently. So this study here is a randomized control trial looking at surgeon versus ultrasound placed paravertebrals, and they found it was a non-inferiority study, and they found non-inferiority between the opioid consumption in the first 24 hours between the surgeon placed and the ultrasound placed blocks, and there was no difference in terms of pain scores, overall time, or postoperative complications between the two groups. So next, we're going to talk about kind of the most popular and most controversial facile plane block, the ESP. ESP blocks are nice because they are superficial and relatively easy to do. They can be placed anywhere along the spine, and they've been called the paravertebral by proxy because they're aiming to block the intercostal nerves by moving local anesthetic into the paravertebral space. They're placed by injecting just below the erector spinae muscles, just on top of the transverse process, most typically. The initial description, the ESP, the authors talked about sensory distribution wrapping around from the medial back all the way around the lateral chest and continuing almost all the way to the anterior midline. However, since then, 2 healthy volunteer studies have been conducted, and only 1 out of 18 volunteers that were involved had any sensory change in the anterior thorax. That being said, a recent study in the CJA, actually not that recent anymore, but last year, or sorry, 2 years ago, compared single shot ESPs to placebo for minimally invasive coronary artery bypass surgery, mid-cap surgery. And they found a reduction in pain for the first 18 hours, a reduction in opioid use, shorter time to extubation, and a shorter ICU stay. So while there remains some uncertainty about whether the ventral ramus is actually blocked with ESP, it does seem to have positive effects in the immediate postoperative period, at least in some settings. Um, for my more complete thoughts on the ESP, you can read about it in our CGA editorial. But in short, I would basically rather use a block that directly blocks the nerves in the desired distribution rather than relying on a variety of possible mechanisms. Which brings me to suggesting something similar, which is the intertransverse plane, or sorry, intertransverse block. It used to be called the MTP or midpoint transversus process block. This is fairly similar in terms of its paramedian approach to a paravertebral. The only difference is that the injection point is above or superficial to the superior costotransverse ligament. So it's about halfway in between the ESP and the pleura. The beauty of this is that the ITP block works by mass flow of local anesthetic because there's macroscopic slits in the superior costotransverse ligament, and you can see the local actually flow through. So when you do an injection at this point, you'll still see the pleura drop in the same way that you would with a paravertebral. And there have been some head-to-head trials comparing the ITP to paravertebrals. This one specifically found that the ITP was non-inferior to the paravertebral in terms of pain scores, and there was no difference in terms of first use of PCA, number of uses of PCA, the consumption of fentanyl, or the side effects. A further systematic review of 8 RCTs found that while pain was similar for the first 12 hours, paravertebrals showed better analgesia with movement and opioid use within the first 24 hours. So basically, in a very brief summary, um, ESP is okay, ITP is better, paravertebral is the best. But it's weighed against the how close are you getting to the pleura versus and thinking about how like what your quality of images is as you progress. So because the ITB block works via spread to the paravertebral space and the ESP relies on potential spread along with some other proposed mechanisms, it's best to deliver the local as close to the paravertebral as possible. That being said, if the image quality is poor, it would be better to place local in the ITP position rather than risk pleural puncture. So the next one is the serratus anterior plane block. We know that these blocks work well for lateral chest wall surgeries from a number of studies on thoracotomy, on breast surgery, on VATS, and on rib fracture patients. In all of these studies, pain, opioid consumption, and P1V were reduced in the first 24 hours compared to either no block or placebo. And the Society of Cardiovascular Anesthesiologists have recommended serratus anterior blocks as being considered for minimally invasive cardiac surgery. There have now been several studies specifically evaluating SAP blocks for minimally invasive heart surgery. So whether it was a mini thoracotomy or endoscopic valve, pain and opioid consumption was reduced compared with no block, along with multimodal analgesia. And it was better than either multimodal wound infusion or intercostal blocks. Serratus anterior plane blocks are typically placed along the lateral chest wall, targeting the lateral branch of the intercostal nerves. There is a both superficial version, which is placed between the latissimus dorsi and the serratus anterior plane, or sorry, the serratus anterior muscle. And then there's a deep version that's placed below the serratus anterior muscle, just above the rib or intercostal space. And in the original paper by Blanco, they reported T2 to T9 anterior, lateral, and posterior coverage for this block. There have been since a couple of distribution studies looking at various amounts of local anesthetic, And it seems that T3 to 6 coverage is the most consistent, with variable coverage to T2 and variable coverage to T7 to 9. So next, I'd like to talk about blocks in relation to thoracotomy incisions. So the prospect guidelines for thoracotomy are now aging a bit. They're going back to 2015. They recommended either a paravertebral or an epidural, but state that paravertebral is preferred. Even now, even though these are relatively old, not a lot has changed in the past 10 years in terms of recommendations. So the Society of Cardiovascular Anesthesiologists have guidelines for thoracotomy as well that state either epidural or paravertebral are recommended. The only addition is that they recognize continuous ESP or serratus anterior plane blocks as alternatives to either an epidural or paravertebral for thoracotomies. There was a Cochrane review. This is again going back quite a few years. It's 2016, but they included 14 studies with nearly 700 patients undergoing thoracotomy, and they compared paravertebrals to thoracic epidurals and found that there was no difference in terms of mortality, complications, or pain at any time point. The only difference was that there was a higher rate of failure among the thoracic epidural group. There is a newer meta-analysis, but honestly, it's of lower quality than the Cochrane, and they included less studies. So they included 7 randomized control trials and about 430 patients. They found that during the immediate postoperative period, the epidural provided superior pain relief to the paravertebral. But beyond 12 hours, there wasn't any significant differences between the epidural and the paravertebral, and there was no difference in opioid use. However, hypotension, PONV, and respiratory complications were actually significantly more frequent in the epidural group. So again, we had a study that was locally done. That was a retrospective study looking at that did a non-inferiority comparison between epidurals and surgeon-placed paravertebral catheters for people undergoing Ivor-Lewis esophagectomies. So again, because paravertebrals are tricky to do, and either they're not routinely offered by your anesthesia group or time doesn't allow, it's possible to have surgeons place them. So in this retrospective analysis, they didn't have, caveats. They didn't have control for confounders. However, they did have pretty similar patient groups with no differences in terms of baseline characteristics that were measured. And of the 92 patients that went through this, overall paravertebrals were non-inferior and sometimes statistically equivalent to the epidural group in terms of pain control. And they were non-inferior in terms of time to ambulation and actually superior in terms of opioid consumption, since there is opioids in the epidural infusion. So next, I want to talk about sternotomy incisions. So paravertebral is technically an option for sternotomy. However, these are deep, non-compressible blocks in a vascular space, so there's still concern about bleeding, and they follow the same anticoagulation guidelines as epidurals. And so given this, there's been a lot of interest in providing fascial plane blocks for sternotomy incisions. A meta-analysis including 10 studies of patients undergoing cardiac surgery via sternotomy was done, looking at ESPs versus no block. And the ESP had lower pain over the first 4 hours, shorter ventilation, less opioid use, and less PONV compared to no block. But that pain control difference was only 4 hours. And however, the prospect guidelines from 2023 state that ESP cannot be recommended for sternotomy due to limited evidence. So that brings us to the parasternal intercostal plane blocks, which is the current forerunner for fascial plane blocks for sternotomies. So they're both a superficial and deep version of this block. The superficial parasternal block used to be called the pectointercostal block, is placed between the pectoralis major and the rib or intercostal muscle. And this targets the anterior branches of the intercostal nerves. There's also a deep version that used to be called the transversus thoracis plane block, but now just deep parasternal, which is placed between the internal intercostal muscle and the transversus thoracis muscle. Problem with this one is there's the internal mammary vessels are right in that same plane close to the injection point. They can be performed in either a transverse or a parasagittal view. And there have been a couple of cadaver studies, dye studies published on this block looking at the distribution of dye. The big caveat here is that dye spread doesn't equal a clinical block, but it seems to find that spread is fairly consistent from T2 to 5. And in general, multi-site injections seem to have better spread than a single point injection. A meta-analysis from 2024 in CGA included 11 RCTs with 756 patients, all getting superficial parasternal intercostal blocks. They showed less pain over the first 24 hours. The effect site was close, but showed shorter ventilation, less opioids, and a shorter ICU stay on an average reduction point of like 8.5 hours for the ICU stay, but no difference in hospital stay. There's currently two trials going on looking at superficial parasternal catheters that are going to be run over several days. One is run out of Toronto that we're a site for as well, and another one's run out of UBC. So once these two Canadian trials wrap up, and they're both like double-blinded, well-conducted, very rigorous trials, when they both wrap up, I think we'll have a really good indication of whether superficial parasternal intercostal plane blocks work and whether the catheters work. Just to quickly mention, as I said, the serratus anterior plane block works on the lateral branches of the intercostal nerves. But several years ago, there was some controversy about whether they would actually also block the anterior branch of the intercostal nerves. So we investigated this block for midline sternotomy at our institution. We ran an RCT, and in some ways, this would have been a great block because they can be placed while the patient's supine and they're far away from the sternotomy wound. But unfortunately, during this double-blind randomized control trial, comparing to the placebo, we found no differences in terms of pain, opioid use, ICU stay, time to extubation, quality of recovery. So basically, entirely negative trial confirming it does not block the anterior branch of the intercostal nerves. So take-home messages for the chest are that in terms of the anterior chest wall, I would recommend a parasternal intercostal plane block. For chest tube sites, we'll talk about this a bit later, possibly the external oblique intercostal block, but I'll come back to that. For lateral chest wall, I would recommend the serratus anterior plane block, plus or minus pectoserratus if you need to be higher up along the chest. And if you're looking to block the whole chest, paravertebral blocks are great. So again, in summary, blocks way out or far superior to no blocks. Local is better than no local. Sternotomy, I would recommend parasternal blocks. For either minimally invasive cardiac surgery or mini thoracotomy, I would recommend the serratus anterior plane block. And for either VATS or thoracotomy, a paravertebral or a SAP block both work great. So next, I want to move on to the abdomen. And we'll start off with a block that I'm sure everybody's familiar with. The TAP block has been around for quite a while now, since it was the first official fascial plane block that was ultrasound guided. That was described in 2007. For this one, the injection happens between the internal oblique and the transversus abdominis muscles. The issue is that this block is actually quite finicky to get the needle tip into the injection plane that you're looking for. And this video honestly makes it look easy, but often there's a couple of injections above or below before you can get the plane to open up. And it doesn't necessarily unzipper quite as nicely as this. And secondly, people have found that in order to get a consistent block, that you need to hydrodissect along the plane with local anesthetic over several inches. And ideally, you progress as far posterior as possible in the transversus abdominis plane. So you can see this one's even going past where the end of the transversus abdominis muscle is located. So for this one, while surgeons can place tap blocks, they tend to do it with a double pop blind injection, which is going to be highly inconsistent about whether they get into that plane. And it's just not going to have reasonable spread along that plane, even if they manage to get into the right spot. So it's going to be an unreliable block from my perspective. Talking about tap blocks, this is a picture of me, of course. Um, if you're looking at a lateral or posterior tap, what you're getting is the lower abdomen. So it'll consistently block T10 to 12, possibly T9. In order to get the upper abdomen, you would have to do a subcostal tap block. And that targets mainly the anterior branches still, even though it's subcostal, because the lateral branch is long since branched off before entering this plane. Another great option for midline abdominal surgery is the rectus sheath block. For this one, the local is injected posterior to the rectus muscle within the rectus sheath to block the anterior thoracoabdominal nerves. This is generally quite an easy and satisfying block to perform since the rectus muscle peels away quite nicely and the posterior rectus sheath is fairly thick. So once the initial injection is done, it's actually pretty easy to advance a catheter to get a continuous block. And I prefer to put the catheter in under ultrasound vision. Most satisfying thing to do, and honestly, it can be no other place if you see the catheter sitting underneath the rectus sheath muscle within the rectus sheath there. It's going to be a very consistent block. This is also a relatively easy block for the surgeons to do. This is one of the few blocks that I've actually done on the surgical side as well. Um, and the beauty here is that the posterior rectus sheath is fairly thick. So pushing the TUI needle through, you can actually feel kind of indent the posterior rectus sheath without being at risk of having the surgeon injure their own hand. And then also, there's not a lot back there. So if the catheter advances easily, it's in the correct spot. If it doesn't advance easily, it's probably most likely in the body of the rectus muscle, and just the needle needs to be repositioned again before advancing the catheter. So the rectus sheath block should be injected more Keflad if possible, and it's going to consistently block basically T6 to 10 along the midline. And so, as I mentioned a while ago, we did this first systematic review, which showed still superiority of epidurals. So there's still an argument there. But the next best is the continuous peripheral nerve blocks. And those are superior than multimodal alone. So if you're not going to do an epidural for a laparotomy, then I would suggest doing at least some kind of fascial plane block. And then a few years later, we did another systematic review. This one was a network meta-analysis to determine which was the best fascial plane block to offer. And the two that came out on top are the rectus sheath block and the tap block, which is why I'm talking about those two today. So next, I want to talk briefly about subcostal incisions. There is, so we'll talk about the subcostal tap. The beauty of this block is that the transversus abdominis plane continues nearly to the midline in the subcostal region. So if you keep the ultrasound transducer parallel to the ribs, just below the costal margin, you will see that the transversus abdominis plane, muscle continues all the way behind the rectus sheath here. And this is different from lower down in the abdomen, where the transversus abdominis muscle forms an aponeurosis at the semilunar line, becoming part of the posterior rectus sheath. And so it is possible to place local just above the transversus abdominis muscle, almost all the way to midline. So you can hydrodissect, and this shows the needle in the opposite direction. I honestly start lateral, progressing towards midline. You can get into the tap plane and continue to hydrodissect all the way underneath the rectus plane, nearly to the xiphisternum. So that being said, the skin distribution is mainly in the midline, since we're targeting the anterior branches of the thoracoabdominal nerves with this block. However, I still think there's probably some use in terms of a subcostal incision, because it's going to be blocking the nerves as they pass through the incision, innervating the muscles, and all those nerves are going to be cut as they go through the incision. It's also possible for surgeons to place these catheters, but whether they're good or not really depends on how the surgeon is doing them. So if they open the plane directly, so some of our surgeons through a subcostal incision will directly open the tap plane and insert a catheter into that plane. And again, I can't beat directly observing a catheter in the proper plane with ultrasound. It's just going to be better if they can see the catheter is in the right spot. However, if they do pop, pop, shove a catheter in blindly, we're going to win every time. So this study, there was following liver resection, surgeons inserted two catheters, one into the tap plane, one into the posterior rectus sheath. And they found good results in terms of pain and opioid reduction. And actually a reduction in length of stay as well, compared to just PCA. In terms of the ultrasound subcostal plane blocks, these have been investigated in living liver donors, living-related liver donors. So the subcostal tap here, they found that there was significant reduction in opioid consumption, shorter anesthetic recovery time, and a reduction in length of hospital stay among the living-related liver donors. You will find tap blocks mentioned in the ERAS guidelines. So here they state that continuous wound infusion provides lower complication rates and overall is equivalent to a thoracic epidural. Local anesthetic delivered in the tap plane also improves pain control and reduces opioid usage. And they also specifically say that for open liver surgery, thoracic epidural anesthesia can provide excellent anesthesia and has significant disadvantages. And going to say that because of the potential for hypotension and mobility issues, it can actually be detrimental to a rapid recovery. So they give some pause there in recommending epidurals. This is a relatively new block. It was described in 2021. It's called the external oblique intercostal block. The key to understanding this block is knowing that the external oblique muscle extends over the top of the lower rib cage, all the way up to the sixth rib. And local deposited under the external oblique muscle, but superficial to either the sixth rib or the sixth intercostal space, can then spread along that plane and is actually contiguous with the plane underneath the serratus muscle to block both the lateral branches of the intercostal nerves, but also the anterior cutaneous branches over the upper abdomen. So in the original paper, El-Shakarawi and colleagues presented a case series and cadaver data showing spread from T6 to T9 at the midline and from T6 to T10 or 11 laterally. So there's been several papers since, mostly case series, that show good effect for upper abdominal surgery. And as I mentioned before, so while there's no formal study, people have shared anecdotally that these are good for blocking subcostal mediastinal drain sites in cardiac surgery. So some people add this block to cover those sites in patients where that's particularly problematic. There's been a randomized trial of 48 patients undergoing open upper abdominal surgery through a J-shaped incision, a couple of different procedure types, and they compared the external oblique intercostal block to no block control group. And they found that the EOI improved pain, decreased opioid use, decreased anesthetic requirements, improved quality of recovery, and contributed to a faster time to ambulation. They've also looked at this for minimally invasive surgeries like a lap sleeve gastrectomy. So in this one, they randomized patients to either getting a bilateral external oblique intercostal block versus no block. And they found that the external oblique intercostal group had reductions in pain for 12 hours and reduced opioid use over the first 24 hours. So the take-home messages here for the abdomen are, once again, local is better than no local. Put it somewhere. Secondly, for an upper midline incision, I would recommend a rectus sheath block. We often do these. A lot of them are surgeon inserted, but they work very well. For lower abdominal surgery, you consider a lap or posterior tap block. I think a ultrasound block is going to be better than a surgeon placed block in this case. And for subcostal incisions, probably go with the external oblique intercostal block. It's very analogous to doing a serratus anterior block in terms of how to do it. So it's easy to learn. Or you could consider a subcostal tap block.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.